reason that they wanted the reason that they wanted me to talk is that they were finding that their staff were having difficulty with interviewing nurses, and that they were having a difficulty with that because they were so anxious and so worried, and all of that that would go around with that. Because of course, if you're going to be talking with the board of nursing and then an assistant attorney general, and of course, it's very anxiety provoking. So I was just asked to do this, and I thought, okay, how do you present to the Board of Nursing? I'd never want to be on their radar, and here we go, I'm on their radar. So I did something with trauma-informed care, and then just this is my attempt to answer some questions that I had for myself as well. So I want to just talk about elements of trauma, immediate and longer term effects, apply principles to a practice setting, whatever your practice setting is. And then, of course, the American Nurses Association Code of Ethics for Nurses. And Martha, I am just like, I'm so glad you're here, but darn it, I'm definitely not robust with all of this. And I am really looking forward to your talk in October, because there's so much in the code, and it's something that I keep right by my bed, by my table here. So I had a question, a clinical question that kind of generated from that board of nursing, like, okay, what am I going to do? Um, so I work at Allina Health. I am not speaking on behalf of Allina Health. I'm speaking on behalf of Niki Gjere as a psychiatric mental health clinical nurse specialist. And what I have learned since the violence, since the legislature passed the statute related to healthcare worker violence prevention in 2015, I remember telling the vice president of nursing at the time, or the vice president of the department, saying, the way this language is, we're going to make nurses victims. We're not going to be able to, we're not going to empower them and help them feel that they can have control over their setting and actually interact with people that are potentially dangerous. And so what I've been trying to do through, like, it's been 10 years now, how do we, I've been hearing that some nurses are saying that they're afraid. Therefore, I don't have to care for that patient. Like, what does that mean? Like, I don't want to work with that patient. I'm afraid. How do I shouldn't have to work with that patient. I have a right to not be, you know, to have all the violence against me. And I agree with that. However, we still have an obligation to care for patients. So however we do that, and however we can facilitate that. So then if a staff member is attacked by a patient, how do we investigate the incident and learn about possible improvements without re-traumatizing the staff member, or having them feel like we're blaming them for whatever the incident was? We don't want to blame the victim, right? And then the Board of Nursing was specifically interested in, if there's a complaint about practice that generates a complaint, how best do they investigate it? And you'll see later on, the National Councils on State Boards of Nursing is really working on this, and they're in a framework of it. So just defining trauma. This is very basic. Many of you on this can give this lecture, and it can be a week's long lecture, right? The American Psychological Association, it's an emotional response to a terrible event. Could be accident, crime,
Niki,
natural
do you have your
disaster.
slides up?
Oh, am I not sharing? Sorry. Thank you for that.
Sorry, didn't want to interrupt, but
There we go.
yeah.
Do you want me to go back?
No, I think it's fine.
Here, let me okay, so I'm in the define. So I apologize. So thank you for that cross check. Is it sharing? It's not sharing the right screen though, is it?
It's perfect.
Okay, good.
Definition of trauma, right?
Good. Thank
Yeah.
you. And we did a dry run today. Kathy helped me with doing a dry run because I'm not as accustomed to Zoom, more accustomed to Teams. So the American Psychological, it could be emotional response to a terrible event, accident, crime, natural disaster, physical or emotional abuse, witnessing violence, death of a loved one, war, more, immediately after event, typical reactions can be shock and denial. So really, there's so many events, there's so many circumstances that could could expose people to trauma. And then longer term effects, possible unpredictable emotions, flashbacks, strained relationships, physical symptoms, and having difficulty with moving on with their lives. So we also experience and hear trauma or hear information from our patients. We live their stories with them. We live their lives with them. We're in that sacred space. So we also can experience vicarious trauma from what we hear, what we experience with our patients' families. It could be the emotional and psychological distress experienced by individuals who witness, hear about, or learn about the traumatic experience of others. I think of those that experience the stories of refugees, of people that have been in abusive relationships, because they're telling us the information, they're telling us their stories. We're assessing them, we're helping them through their with this journey. And then we often will take on that burden of that other person's trauma. So how many times have you gone home or you have finished with that patient or finished with that story and you're still thinking about it, it's still affecting you deeply. And the symptoms do align with primary trauma. There's also something called adverse childhood experiences, the ACEs, and I'm sure this is something that you've heard about. These are some of the experiences that people may have, and the kids could experience violence, abuse. They could witness violence at home in the community. Having a family member attempt or die by suicide. That's a big one that we see in mental health and addiction. So these are experiences that they have. There's also environmental experiences, and there is a full list that's more comprehensive on the CDC website that is linked below. Next, I want to share a slide, or a small video that I think if there's a video that can show or demonstrate it in a little different way than me talking, I'm always happy about that. So cross-check can you hear the volume?
Brain development is much more than a story about biology.
Yeah.
From the earliest years, relationships with others play a key role in shaping how our brain grows and develops. Early relationships, where there is abuse and neglect, have a long-term impact on children. A brain that has adapted to survive in a threatening or unpredictable world may not work so well in an ordinary environment. This can create what is called latent vulnerability, where early abusive or neglectful experiences with carers put children at greater risk of experiencing mental health problems in the future. For these children, compared to their peers, common experiences like moving to a new school can feel more daunting and stressful. New faces can appear threatening, while positive social cues can be missed. It can be harder to negotiate new social situations and learn to trust new people. Even fun experiences like joining a new sports team can be challenging. Too much focus on potential threat cues can mean missing out on positive social cues such as a playful nudge. Or it causes an overreaction, which leads to an increased risk of conflict and sometimes violence. These reactions can increase the likelihood of generating new stressful events. It's harder to deal with everyday challenges when you feel unconfident and anxious inside, and harder to build and maintain relationships. Over time, this can mean a child loses friends and the support of adults, and so misses out on opportunities to grow and develop. This social thinning can increase the risk of mental health problems in the future. Neuroscience research is beginning to shed new light on how vulnerability unfolds over a child's life. All children need care and stimulation from adults who value them and who show them attention and love. These experiences shape a child's brain development. When children face traumatic experiences like abuse and neglect, their brain adapts to help them cope. We know of changes in 3 different brain systems: the reward, memory, and threat systems. Experiences of domestic violence or physical abuse can lead to hypervigilance, where the brain reacts more to threat. This might help a child stay safe in an early adverse environment, but it can cause problems in more ordinary environments. Hypervigilance can best be understood as a pattern of adaptation rather than a sign of damage. Abuse and neglect can also mean a world where a child's basic needs for care and attention are not met. This can shape the brain's reward system, the part of the brain that helps us learn about positive aspects of our environment and motivates our behaviour. Over time, the brain's reward system can learn to respond differently to things like positive social cues. Neuroscience studies have also pointed to changes in the autobiographical memory system, our memory of everyday past experiences. Following trauma, negative memories appear to become more salient, which means they become more prominent than positive ones. And everyday memories can also become less detailed. This is a problem because we need to draw on past experiences to help us deal with new social situations. Neuroscience research is showing how childhood trauma can create latent vulnerability, increasing the risk of later mental health problems like anxiety and depression. This vulnerability is not just located in the child, but arises through their relationships. Helping children who have experienced trauma still requires ordinary boundaries and consequences, but it also requires us to step back and reflect and see behaviour that we find challenging in a different light. A child may simply be doing their best to survive now, with brain adaptations from the past. We know a child's brain has the capacity to continue to adapt. For this to happen, they need our help to build and maintain trusted relationships, manage everyday stressors, and prevent new ones from happening. We need to encourage them to try again and believe things can be different. This is far from an easy task and takes time. Science is helping reframe our understanding of childhood trauma. Seeing children's behaviour in a new light can mean we respond differently. But there is much still to learn. Working together, we can develop more effective approaches that promote resilience and recovery. We can help children build trusting relationships and create opportunities for their brains to adapt in new ways.
So the cost of trauma, when we realize that this is occurring with kids and then eventually with adults, 64% of adults have experienced at least one type of ACE before their age of 18. 17.3 have experienced 4 or more. High school students, when they were surveyed, 3 in 4 experienced 1 or more, and then 1 in 5 experienced 4 or more. And the primary in this study was related to emotional abuse, physical abuse, living in a household affected by poor mental health or substance abuse. And we think about the social programs. So when we're looking at the future as well, we think about the social programs that are being affected by budgets and by legislation. So it's kind of an interesting framework as we're thinking fewer as we go forward. So preventing ACEs could actually prevent, and this was really striking to me, 21 million depression cases, reduce high school student suicide attempts by 89%, prescription pain med misuse, and inequities that were highest among females. The inequities found were highest among females, non-Hispanic American Indian or Alaska Native adults, and adults who are unemployed or unable to work. So then when we apply this, it's not just patients that are experiencing this, people in the public. The healthcare system is populated by trauma survivors, both those providing care and those receiving care. So I think sometimes we pay attention to what is going on with clients, patients, residents, And we forget about all of our staff members, all of our nurses, all of our care providers, our physicians, our providers. So here's just a very brief video about trauma-informed care. I liked this because it was really succinct, and there's a lot of information on the trauma networks. So if you ever need those, they're really helpful. Let me just see if I can get this.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
So the Joint Commission has published a quick safety issue promoting psychosocial well-being of healthcare staff during crisis. And it started talking about the COVID, the pandemic, and all of but it really is applicable to more of the crises that we're seeing every day. And also I think of even by sharing some of the stories that we talk about, and that maybe even shared experiences that we have, we embed crisis and embed trauma to other people. I learned that in some of the schools now, they're showing the 9/11 videos and how traumatic that is, and how concerning that is for parents, that kids are seeing those videos, and the graphic nature of them. It's almost like we need to rethink how are we talking about historical events and sharing the information about them. So healthcare organizations need to have systems in place that do support institutional and individual resilience. With increased healthcare worker stress, we're going to see we have physical isolation from loved ones and colleagues, anger, anxiety, fear. We also want to make sure that we're addressing insufficient resources. I mean, it's there, and I'm not going to like read the slide for you, even though I've already started reading the slide. But it really is, Joint Commission is really paying attention now to this, where between violence prevention, they have now standards related to violence prevention. They have more of these quick tips and what the obligation is for the company, the organization to really work with supporting their staff. When we get surveyed now by MDH, there's also the requirement to meet the legislation for the healthcare worker violence prevention, that statute. So we haven't heard a lot where MDH is asking those questions, but we know that Joint Commission is in their regular surveys. And then additional information about healthcare worker stress. So for individual well-being, it is recommended that we practice self-care. And sometimes we say that a lot, but we don't do it. Or we kind of skip over those sections when we're asked to do that. But it's important to take micro breaks, have good sleep hygiene, partner with your colleagues and really get support from them, stay connected, stay informed with reliable information. We know that the rumor mills go fast, and in hospitals and healthcare systems, it's the best, right? I mean, you can hear something in one unit and then it's exploded and all over the place the next, just it seems like within minutes. Make sure that leaders check in with staff and check in with themselves, and that we encourage staff to do that as well. And then having resilience in the post-crisis recovery. Now, I just know that there was, like, as we talk about crises, and all people on this call are leaders. We're all leaders in nursing. We're leaders in our systems. We're thought leaders. We're education leaders. And so what happens is managers and leaders have a lot of accountability to communicate regularly. They encourage to communicate regularly, model behaviors, and sometimes that's really difficult when talking with leaders, because they're experiencing the same crisis, and then they have that extra obligation of how to help others through it, and also the obligation to their supervisors and VPs and different people. We want to encourage sharing of concerns. We want to demonstrate value of the staff, orient staff to the psychosocial resources that are available, and then proactively monitor and provide active outreach for the staff. And then also to encourage peer support. And I know that there's more companies, more hospital and healthcare systems that are working on or doing some type of a peer support. I need to put a plug in for the Nurses Peer Support Network. And we are happy, Kathy's happy to talk about that. I'm happy to talk about that. That has a definite angle that we're really supportive of nurses and peer support with substance use issues. But we are going to look at branching out a bit to mental health with future work. So that whole peer support and what that means. And I think we have to be careful too that we don't just implement something and say, oh, gee, we've got peer support, because we can harm each other if we don't do it right. And it's just super important to make sure that we're not re-traumatizing people, or that we're not, staying in that muck. And sometimes as a nurse, I know that it's kind of nice to stay in the muck and you kind of complain and gripe and stuff like that, but it really doesn't help us with moving forward. and having resilience in post-crisis recovery. The stress response sometimes will persist, and you'll see that companies and healthcare systems and home care and those kind of, they'll have a crisis, and every now and then it'll bubble up again. You'll start seeing the behaviors, you'll start seeing the tensions, the anxiety, the fear, the worry, or maybe kind of see that repeat. So pay attention to that and utilize the experts that are available to you. And we have many experts in this group, which is great with MNORN. So typically what happens is we have a crisis. We all go around, we deal with it. Sometimes I think Joint Commission, when they come, that's a crisis because we're all like, everything stopped for a whole week or two or whatever. Department of Health is a crisis, power outage, computer downtime, all of that stuff. We all rally around. And then what happens is the crisis is resolved. And we think, let's take a breath, let's recover, let's celebrate that the crisis was resolved in a positive fashion. But oh no, we're on to the next one because there's always something else coming down the path for us. We move on, we don't even recover. We move on, we keep moving, and we get to the next problem or issue. So what would be helpful is if we could truly pay attention to that trauma-informed care or have a trauma-informed approach and really try to pay attention and take some time and do this well. So the substance abuse and mental health SAMHSA, I know it as SAMHSA. Linda, you know it as SAMHSA. We all know it as that way. But Substance Abuse and Mental Health Services Administration, they do have a great resource, lots of great resources about trauma-informed care and trauma-informed approach. And some of those are basically that we have a service delivery approach, that we recognize signs and symptoms of trauma in clients, families, staff, and others involved in the system, and that we integrate knowledge about trauma and practices into our policies, procedures, and we work to actively resist re-traumatization. What we're learning too, I know that critical incident stress management has been an ongoing kind of like tool used for debriefings. The literature has come out, well, it's been out for several years now, but we're really paying attention more to that literature where some of the tools used in critical incident stress management actually re-traumatize people, because part of the model is that we get together in a group and we all talk about our stories, all talk about where we were when certain things happen, what our experiences are. And one of the chaplains at Alina said he was in the military and he was doing okay after an action. And what happened was they did this debriefing. Well, he not only had his trauma to work with and to work through, but he had other people's trauma that he heard about, and then he was re-traumatized and re-victimized. So his trauma was huge. So the chaplains at Alina have developed an acute incident impact debrief process, which takes the good parts of the critical incident stress management and takes away that re-trauma, that re-victimization that occurs. And so we have an approved research study with Stephanie Edmonds, the nurse scientist at Abbott, and also with Alina, to study the aid with the chaplains, and then also a nurse intervention called, like it's a recon, it's called Reconnect. So stay tuned for that. We're just starting that research study, but it's been funded by the Alina Health Foundation. And we're really excited about kind of moving this forward and getting some support. The aid model has been presented nationally, internationally as well, but the chaplains are kind of like, they're really good about sharing, but they really have to be pushed. You know, it's like, make sure you share this with people. We're using it. We need to use it. And staff really see that it's super helpful to resist re-traumatization. So the key principles of trauma-informed approach are safety. So participants and staff feel physically and psychologically safe. And I think these principles that as I was talking, kind of resonated with the Board of Nursing, where there's certain examples of how we do this. I gave an example of an RN at Methodist Hospital when I had emergency surgery last year, and I had an RN who was in the float pool that came in on the night shift. And you know how night shift is in hospitals. Whether you work or whether you're a patient, it can be kind of lonely and kind of frightening. And she came in and she said, "Hi, my name is," and then I work in the float pool, and I just want to let you know my whole job tonight is to keep you safe. You will feel safe. And if you don't feel safe with me, I'll find somebody to help you with that. But you need to tell me if you do not feel safe at any time, emotionally, physically, any way possible. And I will help. And again, if you don't feel safe with me, let me know and I will find somebody to help you with that, whether it be a supervisor or another staff or whatever. And all that just took my anxiety way down. I've never had that experience. I think I've been encouraging people to do that, like that assuring of safety, because sometimes we talk about, I'm going to do your vitals, I'm going to do your IV, I'm going to do your antibiotic and all of these tasks, but not that whole, like, what could I be worried about? What is my pressing need, or what would I feel like if I'm alone in a hospital bed? So trustworthiness and transparency is another principle, and that organizational decisions are conducted with the goal of building and maintaining trust with participants and staff. And an example can be as an effective shared governance model. If it's an effective model, people feel safe speaking up. They can feel that they're contributing to the goals of the organization, to their care, to their practice. Peer support and mutual self-help are key for vehicles to establish safety and hope, build trust, enhance collaboration, and utilize lived experience to promote recovery and healing. And again, the Nurses Peer Support Network, so it's on this slide as well. And then also, like, various systems will have like a center for well-being or some type of centers where it's in like an EAP or some type of well-being, uh, like some type of a house or well-being center, whatever the company would call that. Collaboration and mutuality, importance is placed on partnering and leveling the power differences between staff and service participants. I think we have a long way still to go on that for mental health. I think we still do a lot of, that imbalance. But patient advocates support that, having patient and family advisory boards. Leadership is really helpful with that, with how we set the culture for how we treat people, how we treat our patients. And sometimes I slip into, and Kathy, I think you know this about me, that I don't call people patients sometimes. I call them, they're all people. I'm on IRB at Alina Health, and I call them potential participants. They're not subjects. So I try to really keep people human and really paying attention to that, because I don't like to be called, the whatever. It's too easy to objectify people. So also empowerment, voice, and choice is one of the key principles, and that the organization fosters a belief in the primacy of the people who are served to heal and promote recovery from trauma. So we partner with patients and families, again, those patient and family advisory boards. If we're going to implement something where when you come into the emergency department and you're a mental health patient, if you come in because of mental health needs, we're going to make sure that you get changed. Well, how do we do those searches? How do we do those in a very kind, non-traumatizing way? And we can all tell stories. That's not the purpose of this meeting, that I tell you lots of horror stories, but there's a way to do this work and way to do these interventions and care in a caring way and in a non-traumatizing way. Cultural, historical, and gender issues. Culture and gender responsive services are offered while moving beyond stereotype and biases. And we work to provide culturally sensitive food, hair care products. Our spiritual health services is really a great resource wherever that is, if it's a community's resource, if it's a uh, hospital, if it's a work, like a non-healthcare system. I was just talking with our pastor at church last night about some of these principles and some of the pressures that are going on politically, and how are we continuing to support with culturally sensitive care and just being with people. So seclusion and restraint, I'm a psych mental health CNS, so of course I'm going to say something about seclusion and restraint. And they're called out specifically for their traumatizing practices. And it's whatever we do to decrease and partner and engage with a patient is really important, because every time it's very traumatizing. It causes psychological harm, can cause physical injuries, sometimes death. We have to get away from using seclusion and restraint for whatever we can do. We work to decrease those episodes, but I feel sometimes that um, the violence is increasing. Sometimes our compassion is decreasing. Our worries are in, so there's so many factors that are going on. So that's why it's so important that we do what we can to have trauma informed trauma care. And SAMHSA is really working to decrease coercion, decrease violence. And the American Psych Nurses Association has said that yes, we need national initiatives for this, but the only thing that is sustained for reducing violence is engagement. And they say patient engagement. And it's not patients engaging with us, it's staff engaging with patients. And that's what we find, that sometimes we're dismissing people, or we're pissing patients off, or that kind of thing. So whatever we can do to really support staff in being able to have the capacity to care for patients and really treat them well. And here's the American Nurses Code of Ethics. I keep this handy. The American Nurses Code of Ethics for nurses really does speak to why it's important, because even though I may be traumatized and I may have fear and anxiety and possibly anger at my patients, I have an accountability in the code to make sure that I'm still caring for those patients. And if I don't feel like I can do that, I need to take care of myself so that I can provide effective care. And we need to make sure that if I can't do it, then somebody else will be able to. I can pass it off. I know myself well enough. I have to be able to pass it off. So the Code of Ethics does not let us off the hook with caring for patients because we're afraid, or caring for people that are not people that we like to care for. And I think we have done this well. I won't even say that. I think that we have all these folks that we care for every day, and they may be unhoused, they may be negative, they may be yelling, they may be using drugs or whatever. They need care, and I still have an obligation and an accountability to provide care. I do some work with nurses who have an order from the Board of Nursing to because they're in trouble with the Board of Nursing. And I always make sure that they have the Nurse Practice Act and the ANA Code of Ethics, and that they read that cover to cover, and that we talk about that, and that's incorporated in their plan. So in advocacy, the National Council of State Boards of Nursing is working on trauma-informed interview process for their licensing exams, and also identified psychological trauma as a risk factor for substance use disorder in nursing. We knew this, and it was really heartening to see that fairly recently the National Council of State Boards of Nursing are working on this to integrate it. So with the Minnesota Board of Nursing too, they have that legislative mandate, they have a wide scope, and they have an extensive practice and education accountability for the protection of the public. So if you think about it, so we started out with talking about trauma, talking about what that means, how it affects our patients, how it affects us, how we can work to reduce that, how we can be trauma informed, And then also that piece about how we're still accountable to provide care. So I have a license, I have 2 licenses. So I'm accountable to provide care no matter I may still be traumatized or I may be experiencing something that is a crisis. I still have an accountability to care for that patient. I still have an accountability if if I've had violence against me. Um, uh, I've been hit, bit, kicked, many, like all of this stuff. I still have an accountability to take care of patients. That doesn't give me like a get out of work free card. I still have that accountability to take care of my patients. I have it's in the social policy statement. It's in the code of ethics. I mean, it's all over what we need to do. And I think what I'm doing at my work site or what I'm trying to do is really start infusing. How are we doing this? We still have an obligation. How can we help you care for these patients? So for the Minnesota Organization of Registered Nurses, I know that I've given a little bit of time, but I'm wondering if we can open it up now for discussion from you, not from me, because you all are going to be able to answer questions for each other because you're all experts in this. And I wanted to show you that these are resources and there's a trauma-informed care, like there's tip 57 that SAMHSA does. That's really helpful. A lot of these are super helpful for resources. So thank you very much, and please feel free to reach out if you have any questions. And thank you for your time. And I'm going to stop sharing now, if I can figure it out. So thank you, everybody.
Thank you, Nikki. And do people have questions? First of all, maybe Rachel, could you talk about what's happening in Mankato that you put in the chat?
Yeah, absolutely. I'll take my avatar up here. So the Blue Cross Blue Shield and some other partners in southern Minnesota have collaborated to create the Center for Rural and Behavioral Health. It is a center that is providing mental health care, particularly trauma-informed care for children and families. And their director, her name is Darcy Davis Gage. She is a licensed therapist for something, but they've also got family social workers and family therapists and stuff. But they're working on initiatives to provide trauma-informed care. We cover a 7-county radius around Blue Earth County. Trauma-informed care for first responders, especially with suicides. Then they're also looking to really hit farmers in rural communities, not just farm owners, but farm workers, because they are seeing an increased mental health acute crises in farm workers, especially as some of the costs have just been very unstable for farmers the last few years. And what's really great about the center is they're pulling in students. So it's our graduate social work students, our graduate LMFT students. We're working on getting some nursing students in there that they're starting to place them in these hubs rather than just trying to get to just Mankato. But they could be a great partner. I know they're looking for, opportunities out in the communities. It is focused on rural though. But that trauma informed piece is a really big part of their mission.
That's really cool. Thanks for sharing that.
Yeah, they just opened this spring. I got to do some shadowing there for part of my PhD work, looking at health disparities for children in foster care. And one of the therapists actually is an LMFT. She has several foster families on her case, and I learned a lot. And then, especially with me, I'm born and raised around the Mankato area, especially my community. I co-chair a local collaborative that has a lot of trauma-informed care in there as well. And we just started a partnership to try to work smarter, not harder. So I'm not sure where you're located, but what phenomenal resources, and they the director is like a guru at grants and funding, and then so are some of the other staff, which I know is like a barrier for a lot of people because I think they just submitted for like a $300,000 grant to get these students implemented into health systems in the area.
Other comments? I saw a lot of, Zoom is so fancy now with their little hearts and things that can just float through the screen. It was fun to watch that during the presentation. Sarah, do you want to talk a minute or two about the Nurses Peer Support Network? I don't see Sarah responding. No, Niki, you're still on the board. Oh, Niki, do you want to say something more about Peer Support Network?
It's growing. We have a new executive director. We're going to have our first board meeting on Saturday, but they have many, many, many nurses that are served. Over 400 a month in the rooms now, where they do that virtual in the rooms for that support, the peer support. It's we're doing a lot more with getting the word out. We're working a fair amount with, I've been getting calls recently from nurses saying that they have investigatory meetings with leaders and they're feeling anxious, suicidal. They're afraid. And so there's some of that kind of work going on that we're trying to work on making sure that some of the labor unions have information about NPSN so that they can link up with one of our great resources, one of our conveners. Is that kind of helpful, Kathy? I feel like I'm kind of stumbling.
Yeah, no, that's great. I think for me, the thing that's really peer support, the organization's been around for 10 years, maybe close to 11 now, because time flies. But when COVID started, the peer support meetings went virtual like everything else did. And I was not a believer. I thought, oh, you could never do that in a virtual environment because you have to have people in the room. And I was totally wrong. And so they have like this one platform that they use that in the rooms, and they'll have like 100 people at a meeting, and it's successful, and it works for folks. So the reach that this organization that operates on very little money is amazing, and needs to be applauded. And I see that Sarah had trouble with her mute, so I think we covered it, Sarah. Anyone else have any questions, comments, anything that's going on that they know about for
This is more of a question than a
right.
comment or sharing, but how does social media and very violent TV contribute to trauma? I just feel like that so many TV shows are so violent now and people watch those over and over and over again. Social media posts are so difficult and depending on what type of post it is, demeaning and I don't even know what some of the words are, to influence people so strongly. I would think that that is also causing trauma.
I think any of our members can speak up to this one because I think I know that there was literature that David Walsh was studying this a long ago, a psychologist in Fairview, and he was one of the first ones that I new that started looking at like video games and things like that. So I think all of us have some experience. So everybody else speak up. I'm done talking. But I think you're right on. The more we're exposed.
I've been pretty impressed. This isn't about social media or violence, except that it was real violence. But after the shooting in the church, and that the medical staff is testifying about what they saw, and and I wonder how they're reliving it. Well, they're probably reliving it all the time anyway, but they're telling the story and telling the story over and over again. What does that do to them? Does it help them, or does it keep them in a spot? But I think that for a long time we've heard that nobody really understands how graphically these assault weapons are in damaging bodies. And so I really applaud them for going to the legislature and telling the legislators, this is what we see, this is what it does. But I worry about them and their recovery. Any other comments from anyone?
Can I just suggest that if you're in a work setting and you start experiencing if there's a crisis or trauma event or something that we do pay attention to it, because I think right away people say, I'm fine, everything's good, no problem. But we also know that that people start having, maybe it's not the first day or two, it's it's a week, it's a month, it's, those, be careful, just kind of pay attention to the different, just people and check in on them.
This is Mary. I was gonna wonder, the videos I thought were really good, and I'm wondering if faculty would like to use them for different events. So I don't know if you or Kathy could give us the links to those, to share.
Yeah, we'll be sharing the PowerPoint, so they're embedded in it so that you can pull them out.
Oh, good. Okay.
And Mary, you may even find something better out there, because there is so much out there. So even if you get to the big link, the parent link, you're going to find other links. So
Okay.
point you to it.
Okay.
Anything else tonight? I'm seeing some clapping.
Yeah.
Thank you for your time. Thank you for your attention. Thanks for what you do. I really appreciate this nurse leader group. I appreciate MNORN more than I think about this group a lot. So thank you.
Thank you, Nikki. And Martha, you have raised your hand.
Yeah, just one last word about military veterans and their families, and being especially aware of people who have served, that they may need to at least be listened to or asked about their experiences, whether even if it seems totally unrelated to what you're seeing them for now. But family members and military members have often experienced things that they've buried quite deeply and don't come out until they've experienced another kind of trauma, car accident or sick child or something like that. So military veterans should be identified and paid attention to, especially.
True. Rachel, then Linda.
Oh, I just had a quick question for you, Kathy, if we have enough nominations for positions, or should we send out a follow-up email?
Yeah, I'll be working on that tomorrow. So just
Oh, okay.
everyone, by September 30th is the close for your to self-nominate for a position in MNORN leadership. And so we're coming along with applications, but if you're interested in serving on the board or on the nominating committee or being a representative to membership assembly, you can contact me to get more information. Thanks for asking that, Rachel. Linda.
Oh, I was just going to mention when somebody mentioned the military families, that is a pretty big deal. I actually had my whole doctoral project was on this exact issue about secondary trauma for family members of, active duty military people that really do suffer. They really do. And it was kind of amazing to me that there was quite a bit of research on like professionals with it, but not a lot for that at that time. That's been about 10 years now, but still, it was quite amazing to me that there really was not a lot there. And I don't know if anybody's familiar with the military, but the culture really doesn't, it's not conducive to giving a lot of support for them. And that can be really a lot of challenges for them. So I appreciate that comment.
Thanks, Linda. Martha, did you have anything else you wanted to say?
Yeah, I'd like to talk to Linda sometime. Sounds like an interesting paper. Or could you send me a link to it if you can do that?
If I can find it again.
We're in
trying
the
to get through that.
We're in the midst of writing scope and practice standards for nurses taking care of military members and veterans and their families. And so we can use all the help and information that might be available. So I'd love to see it if you can resurrect it.
I will look for it. The whole process of getting that thing published was quite traumatic. So I had my own trauma after that, but it's gone now. I mean, for what that, but that was quite a thing with the all of the technology and everything and trying to get all that stuff published. It was quite an experience. But I will look for it. Could be I have it on a hard drive somewhere, but yeah.
Okay.
And what is the student? I don't remember, but I know everybody who gets a doctorate has to publish their project in that student publication, and I don't know what it is. But I don't remember now, honestly.
Is it ProQuest?
Yes, I think you could find it on that because I did see, I got little notices in the first 5 years about people looking at it for some of their research all around the whole entire world. That was really kind of cool. I was kind of impressed with that, how much it reached. I just thought, who's even going to be interested in this?
Oh, did you have the same name then?
Yes, yes.
Okay.
So, and I see in the chat that Julia worked with the military for 16 years at Walter Reed. So you have another resource, Martha.
Great. Well, as we get sections of this ready for review, I'll probably run it through MNORN then.
Great. That'd be great. And Niki Gjere just found the article for the dissertation for you.
Thanks, Niki.
That was it. There it is. It's still there.
It won't go away, Linda, so you got it.
I don't think anybody's really, and maybe there's quite a few programs since that time because that was 2015. But at that time, there were just not, not really for anybody, like parents. I know somebody mentioned working with foster kids, but not even foster parents. I did kind of work with somebody out of the Twin Cities who had some stuff with foster families that were really, some of those kids can be hard. And I mean, they go in with good intentions and it's really hard, sort of like a military person. It's really hard with some of those kids who've experienced so much trauma and so many difficulties with their behavior and stuff too, that she had worked with that, but there wasn't really a lot even on that. There really wasn't a whole bunch on secondary trauma for lay people that are in different groupings. So.
Great. Well, this is these are always interesting meetings because everyone's connected somehow or another, and I love that kind of sense of networking that can happen here. So and Nick, I'll be sending you an email tomorrow, and so yeah, Nikki said we could do a week-long conference with these topics. Yes. Okay. With that, I think we'll call it a night. So thank you very
Thank
much,
you all.
all of you, for
Thank you,
attending.
everybody.
Yeah. Nice evening.